All right. Thanks, Ann. Off to our first segment of the day. Just a little bit of background, and before I start with the background, Slido is back. So you can use Slido. We got a ton of questions yesterday. Bear with the team. It's they're compiling them as they come in. Be sure to up-rank your the questions. Even if you don't submit one, you can up-rank it to the top, and we'll try to get them answered either through the panel or perhaps we'll voice it from the back. So our next panel is going to be I know is going to be great. The NASM report, as was discussed I think yesterday, and a little bit more detail you'll hear about today, recommended that primary care teams be trained where they work and also where they live. So the next panel is going to learn from leaders and share what they know from leaders in different settings who are preparing our future workforce for team-based care, where clinicians work at the top of their licenses and the talents of others are tapped to their fullest extent. So with that, I'd like to invite to the stage Jared Skillings, Tracy Solt, Margaret Flinter, Leanne Chrisman-Kwan, and the next section is entitled Primary Care Teams, Training Them Where They Work and Live.
Okay. I'm third. I'll sit over here. Right? Okay. You want to sit in the middle?
Either one.
There, you can sit in the middle.
Great.
It is bright up here.
Well, good morning, everyone. Well, that was not a lot of reaction.
We'll put you right over here.
Okay, I'm going to ask the inevitable question. Who is a morning person? Raise your hand. Okay, that's more than who just responded, but that was about a third of us. That means the rest of us are still having coffee. So we are glad to kick off today. I'm Dr. Jared Skillings. I'm the Chief Clinical Officer for the American Psychological Association. It's my pleasure to moderate this panel. I'm going to offer a couple of very introductory remarks before you hear from these terrific doctors about what they're doing in their communities. I've just gotten to know them this morning a little bit, and I'm already impressed, and so I'm sure you will be too. Just by way of a little bit of context, it sounds like yesterday there was some conversation about the National Academy's report. What it's about, just to make sure everyone's oriented, it's actually about implementing high-quality primary care. There were actually 5 main points that the report hit. They were suggesting, as this whole conference is focused on, that we have to ensure that high-quality primary care is available to every individual and family. They suggest changing the payment model so that pay for primary care is for teams to provide care to people, not doctors to deliver services. They suggest, number 3, to train primary care teams where people live and work, as Ann just described, to design information technology that serves patients, families, and the interprofessional care team, and lastly, to ensure that high-quality primary care is actually implemented. Because one of the things, if you read the report, it has these wonderful vision statements, and it harkens back to previous reports also approved by the government. And unfortunately, the results are that we didn't actually implement this and reach primary care's potential as much as we could have. So what we want to do today is actually look to the vision of that report, look to the visionary leadership not only of Ann and this board of directors and where this organization's going, but to really capture what I think was said in one sentence really stuck out to me in that report. The sentence reads, "The nation deserves nothing less than high-quality primary care for all. But creating such a system requires leadership, accountability, and a clear path forward to accomplish this work." So what you're going to hear today is 3 examples from different sectors and different places about how they've been successful in some really important ways. I hope you'll be able to learn from that, and I hope you'll ask us some questions at the end so we can all learn from each other together. Thanks very much. And Let me introduce our panel here. I'm going to do everybody all at once. I'm going to just introduce them primarily by title, and they can say anything else they'd like personally or professionally about their work here in a minute. First, I'd like to introduce our first speaker, which is Dr. Tracy Solt, here on my left. Tracy is the Director of Clinical Services for the National Veterans Health Administration Office of Primary Care. Down on the far end is Dr. Leanne Chrisman-Kawam. Leanne is an assistant professor of family medicine in the Department of Social Medicine, an assistant clinical professor in the Department of Family Medicine at Metro Health, Case Western Reserve University School of Medicine, and medical director of Metro Health's Doctor on the Street program. And last but certainly not least, Dr. Margaret Flinter in the middle is the senior vice president and clinical director of the Community Health Center. Let's give a big round of applause for Dr. Solt, who's going to come up and join us first.
That is really bright, so I think Leanne and I decided we would stand up here instead of sit for our opening remarks, so I hope that's okay with you guys. And thank you for the kind introduction. My name is Tracy Solt, and I am the Director for Clinical Services for the National Office of Primary Care. And under that purview, I am responsible for monitoring and oversight, quality management, coordinating the traveling veteran care, and clinical learning. And so, and I've been in this role for about 4 years, been with the VA since about 2008. And I just want to say it is a privilege to be up here, kind of humbling to be up here with you guys. And I wanted to echo Anne and Admiral Levine's comments about Dr. Carolyn Clancy. She received the Barbara Starfield Award last night, and Dr. Clancy is just probably one of the smartest people I've ever met. I don't know if you've ever met her. I would encourage it. She's an extraordinary leader and has been a steadfast advocate for primary care for a long time. So educating the VA and the nation is one of VA's foundational missions. In fact, for the past 75 years, VA has partnered with academia to train healthcare. And it really dates back, healthcare professionals, physicians, it dates back to the end of World War II. After the Allied victory, we anticipated about 100,000 new patients without the capacity. And so really it was an innovative thought at that time to partner with the medical schools. And to this day, we continue to train physicians and other healthcare professionals. I want to say 70% was the last survey I saw. 70% of all physicians have received some training through the VA. And annually, we train, I think, about 113,000 healthcare professional trainees. And just a little background about the VA, for those of you that aren't familiar, we provide care, or primary care, through a model called PACT, Patient Aligned Care Teams. And it's VA's brand of patient-centered medical home. And in our primary care in fiscal year 22, we delivered we completed 21.6 million encounters for 5.2 million unique veterans. And we have about 5.4 million veterans assigned to primary care panels throughout the VA healthcare system. And just a quick example of our PAC team. We have a core PAC team and an extended team members. The core PAC team is a primary care provider. It can be a nurse practitioner, a PA, a physician, and the ratio for that is 1 provider to 3 core team, and that's an RN care manager, a clinical associate, which is generally an LPN, and then an administrative associate. But what we're really proud of is that's great, but our extended care team members include a clinical pharmacy specialist, social workers, dietitians, and we have primary care mental health integration, as well as PT and PACT, which is really a lot of fun. But I heard you guys talk a little bit about funding, and a lot of times people are like, VA has the best funding. Well, we do have great funding, but we struggle in primary care as well, in that only 8 to 9% of the total budget for VHA is spent in primary care. And I think that's more than the private sector, but still, I think that's a fact worth mentioning. So in 2010, we implemented patient-centered medical home and our brand of PACT. And so we really had to educate begin to train three different groups of people: leadership, the existing staff that had been trained that had never learned, and then new trainees. We had to change the way that we bring new trainees into the system. So for our existing workforce and our leadership, we created collaboratives. They were regional. We provided an overview of the PACT model, and then developed standard curriculum and centers of excellence that allowed us to train the existing trainees who had never heard of patient-centered medical home. And we still sometimes struggle with that. It is not, we have a lot of good spots, but we still do have some challenges. But what's really exciting, and I think that you guys probably want to hear about, is how we train our new trainees. And for the past 10 years, we have, at 7 different sites, I wanted to highlight some of the good work that they're doing. It's Cleveland, Boise, San Francisco, Connecticut, Puget Sound, Houston, and Greater Los Angeles. And these sites bring in interprofessional training. They train docs, nurse practitioners, PAs, social workers, clinical pharmacy specialists, and regular RNs all together. They receive didactic training together. They go to the clinic together. They have reflective sessions together. That's kind of how it goes, that whole circle. So in these past 10 years, I think we've trained 1,600 trainees in those 6 professions. They are co-led, co-precepted, and the good news about that are some of the outcomes. I think I wrote down some of the outcomes here. So we've had improved staff satisfaction. 90% of the staff are positive about their job. 69% believe they have more satisfaction after participating in this program, and only 26% reported burnout, which is less than the comparison. Our trainees reported improved satisfaction in the training. They felt the training was valued. They felt like it was going to help them find a job. They felt prepared and continued to use the skills that they learned. And they said, which was impressive, that this experience made them better healthcare providers. And then the quality, improved better chronic disease management, A1Cs improved, renal testing improved. There was a decrease for older patients with the use of high-risk medications. There were more timely mental health referrals and decreased ED and related hospitalizations. And I just wanted to read a quick quote from just a registered nurse who was on staff that had a comment about the experience. She said, "I'm part of that conference," and that's the team, the interprofessional team conference she's talking about. "They consider my expertise as a nurse, and the social worker and other residents from other teams will be there too. And the primary care provider who's going to be presenting it will be talking and getting information and make up a plan how to deal with the patient." I really like that. I really like to be part of everything. And I think that's just so important, that we understand each other and that each member of the team considers themselves important. And I think the way that the VA provides this interprofessional training really aligns with the recommendation from NASM, training people where they work and live. So thank you.
Hi, I'm Dr. Leanne Chrisman-Kawam. I am also familiar with your program, being in Cleveland. When I used to work more at Case, that was a place that I did some work, and I also am a benefit from that VA training in Portland. So I am a family physician by training and part of the Department of Social Medicine, actually at Ohio University Heritage College of Osteopathic Medicine. I get why they left it off. It's a really long title. My clinical site is at Metro Health, where I also direct Doctors on the Street, which is a program to meet individuals experiencing homeless where they are, to train both residents and family doctors of the future, as well as medical students, empathy. So we do a lot of reflection around that. I'm here to talk about the development of the inpatient team as your usual source of care, but doing it in this combined way. So just quickly, by just a raise of hands, how many folks here are familiar with the international form of football? World Cup is going on now. Okay, well, so not everybody, leave your hands up. How many that are left know about American football?
Well, kind of, sort of.
Yeah. Okay, how many that are left know about orchestra or music? Are we hitting most folks? Okay, so what I want you to imagine is a really functional professional, interprofessional team. So, imagine FIFA, or imagine, the best team in the world. And I want you to think about the star, okay? Yo-Yo Ma. I want you to think about LeBron James. I want you to think about the GOAT, Tom Brady. I want you to think about Messi or Ronaldo, right? Does that hit everybody in the room? Hopefully. Okay, so you've got your team in your mind. So, how functional would these guys be kicking the ball, playing over and over and over again, practicing their skill, and never practicing with their team? And strangely, this is how we've organized medical school, nursing school, social work. It's bizarre to me. We want this really functional interprofessional team, but we really train in silos. And even so many of the really innovative teams, we send them off to their school, right? We send them to dental school, we send them to medical school, we send them to nursing school. We wanted to rethink that. And I think right now, care is really, really siloed in America, right? Specialty care, hospital care, outpatient care, counseling. And we want to be the usual source of care because we can do it better when we're all together. I've always said where the magic happens is between individuals. So where that Venn diagram overlaps and you've got skills and I've got skills and we do it together, that collective we elevates medicine. So how do we train for this? This is really complicated stuff, but primary care and family medicine in particular, the specialty is all about complexity of care. This is what we do. Dr., I'm thinking it's McLean, you talked about that yesterday. MacArthur, I'm so sorry, my name thing's so bad. He talked about that yesterday about what the specialty is and how we meet our needs. And it really is about working together. It's about relationship. It's about having the patient at the center of that team. So why don't we train with the patient at the center of that team? So we've created a very special 3-year medical school to family medicine residency program in which all of the students train from the first day of medical school in their future family medicine residency site. And rather than that 3 years being less, we make it more. They get training in health system science, public health, population health, patient-centered care. They are videotaped regularly, and we review those videotapes in this very reflective manner, and we watch them leapfrog their colleagues in terms of clinical skills. But I think the core thing is that we trained all of the professionals that are in our team to be faculty. And now we're bringing in trainees from all those other places. So we've trained them in our shared mission, vision, values, and goals. We have a common language. We teach team steps. We don't just teach it, we utilize it daily so that that language is constantly being used. And then we have them evaluate each other on those goals and skills. So it's about de-siloing care. Those students are reliant on everyone in the office as their faculty. They get to do all the jobs in the office. They are the front desk staff. They are the nurse for the day. They are doing all of those skills all of the time so that they don't think that those skills are not important. And as they become doctors, they have a sense of how important their team members are. So finally, I just want to say that in addition to being patient-centered and having all these kind of evaluative things where we're training doctors, the patient is also a key stakeholder in that, and we teach them to go out into the community and figure out what populations need, with those key stakeholders to partner with the community agency and bring new care partnerships to our primary care. So not only are we practicing this very team-centered care in the office, we're getting outside. And just 2 examples quickly of that. We have a person who has started a pantry at Akron General, which is a safety net hospital, where she has developed the boxes with the local produce grower, with the nutrition department, and with the food pantry, and developed a video series on how to use those boxes, which have been designed for disease states, hypertension, diabetes, etc. And so even if patients don't know how to use the food they're getting, they learn how. That's one example of a community project. Another community project that I think is very cool is one involving mental health, in which we're dealing with chronically homeless individuals in that Doctors on the Street program. And one of our folks said, how do we get them into permanent housing? How do we make this happen? Started working with Frontline, which is one of our mental health agencies, and developed a program whereby their residents now are providing the care oversight, the medical care oversight for individuals who have chronic, complex medical conditions, chronic persistent mental illness, and chronic homelessness with Frontline, because they didn't have a usual source of medical care. They had a psychiatrist, but not a usual source of medical care. And so we see this need, we see a population that's vulnerable, we match them together, and these are medical students that create these projects and then carry them through their residency. So I think by doing this, we can change and de-silo the care so that we are collective we, where all the magic happens, where we work together. So that's our little gig, and I appreciate the time to have a voice here with these other amazing ladies. Thank you.
Wonderful. Well, thank you, Tracy and Leanne. And, at risk of oversharing, Tracy, when it comes to the orchestra, I'll say that I had a routine colonoscopy a few days ago, and I had to call the office back afterwards and say that was orchestral level. That was the expression. It was orchestral level teamwork and coordination. I just could not believe it. Unfortunately, primary care doesn't work in quite such nice, tidy sequences, but nonetheless, that was a great analogy. So thanks for having me here. It's a pleasure to be with you. Last night was wonderful, and thank you so much for organizing that, for all of you who sponsored awards. I could feel Barbara Starfield in the room, and also some of my most admired, now departed heroes like Jack Geiger and Fitzhugh Mullen, people who worked so hard over their lifetimes to make really wonderful primary care a right and not a privilege. And it's really great to be with all of you who share that vision. I hope you don't mind, but I'm going to use notes because, as I said to somebody earlier, I can talk for an hour without notes, but if you ask me to talk for 7 minutes without notes, I'm really sunk. I'll never get to it all. So I've had the pleasure of being asked to describe our work to bring team-based care and education and training to community health centers, and that ties directly to the NASM recommendations. I think the good news is we actually have a bit of a good start out there in primary care. Now, I am a true devotee of community health centers, a system with 1,400 organizations, about 9,000 sites, and 30 million patients. And my own community health center up in Connecticut takes care of about 150,000 people in sites all over the state. We started as a free clinic with the purpose of making healthcare a right and not a privilege, and it still underlies what we do. But training the next generation is now core to what we do, and to trying to help other organizations do the same thing, because I think the survival of primary care depends on it. I'll say it now so I don't have to keep saying it again. We also hold a HRSA National Cooperative Agreement to make real on the promise of trying to help other people do anything that we believe we've done successfully and is replicable. We want to help other people be able to do the same thing. And Tracy, of course, we have so much respect for the VA. You've always had that as part of your central mission. So I'm going to start talking about education and training and then go to team-based care. But I'm going to look at training in health centers and in primary care generally about what's possible, looking at maybe a couple of different buckets. The first one is the one you're all the most familiar with, probably welcoming students of all the disciplines into your organizations, potentially giving the nursing student, the MA, the therapist, the pharmacist, the community health worker, an opportunity to actually see primary care in action and to participate as part of a primary care team. Because if we don't bring them in, they are not going to have that vision or that understanding of what primary care is, and that's critical. Health centers have really stepped up. 82% of health centers, 1,129 of the 1,400 health centers are formally engaged in health professional training, 15,000 preceptors. We just did a national study for HRSA called the Readiness to Train Assessment Tool. The vast majority of health centers are ready and willing, but they need help and support, both the technical assistance we can support, but also funding for some individuals to manage those programs. The second, which some of you are familiar with, is formal postgraduate residency or fellowship training for primary care providers in FQHCs. The Teaching Health Center movement created opportunity for health centers to create physician residency programs, and that's been highly successful. But in 2007, my organization looked at the growing shortage of primary care physicians and the growth in primary care NMPs and said, who wants to be a primary care provider? And how can we provide them with an intensity of training appropriate to the complexity, both clinically and socially, of the patients we see? And we launched the country's first postgraduate nurse practitioner residency training program. There's now 110 programs in community health centers around the United States. And while there was no funding for them for the first 10 years, and I'm sure a lot of people on Capitol Hill ran in the other direction when they saw me coming, there has been funding now for several years from HRSA, and we certainly expect that to continue. Those are not only primary care NPs, but also psychiatric mental health NPs who will practice in the primary care setting. And again, Tracy, congrats to the VA for all their work in that area. Really want to encourage other people to consider that model. Long-time results of just our alums over 15 years, 120 alums, we were able to get 75% of them to respond. Over 70% are practicing as primary care providers, many with other roles within their organization, leadership roles, but practicing as primary care providers, and more than half of them are at FQHCs. That means the other half are in some of the other practices represented here. 3, if you want fully integrated behavioral health in primary care, you need to create opportunities to train to that setting, and that is really true for our clinical psychologists. And Jared, we might connect on this later on. There's only 2 postdoctoral residency training programs for clinical psychologists in community health centers, and we're one of them. We think they should be in all of them. Clinical psychologists, as well as the other members of the team, are critical to the integrated care model, and if you do not train in an integrated setting, I'm like a broken record on this, the chances are you aren't going out looking for that as a primary focus when you decide where you're going to build your career. We've had our program for 10 years now, highly successful. The next one I want to talk about is the last of the innovations, perhaps, in training. Might be the most exciting. When we think of training people where they live and work, training to a model of high-performing primary care, we look at the critical role of the medical assistant, the team member who is most likely, in my experience, to come from the neighborhood and the communities where FQHCs, health centers are located. And in our experience, also often the first person in the family to pursue post-high school education. We were dismayed by the state of medical assistants in interviewing people for positions and what they would tell us about the amount of debt they incurred for their training in, I'm sorry, but I will say it, in proprietary organizations with a truly far less than training to a high performance model of primary care, to put it mildly, and came together after a few years of study with Salud Health Center out in Colorado and created NEMA, the National Institute for Medical Assistant Advancement, a national accredited school now. It's based on a partnership with high-performing community health centers and other primary care practices. Now 50 national training partners in 17 states, 250 medical assistant students. And I will tell you, I think this is utterly transformative for those individuals and for our practices that have the benefit of MAs who are trained to a high-performing model of care. So while we're training to clinical complexity and high social needs, and we're training those individuals, we do have to look at the team-based model of care, which I think is the only way we can do this work. So let me spend just a few minutes on this. Now, maybe I feel so strongly about team-based care because, to tell you the truth, I don't think I've ever known anything else. I walked into practice as a family nurse practitioner and National Health Service Scholar 7 years after my organization was founded, and we just celebrated our 50th anniversary. And I actually walked into a true medical home with a not bad version of team-based care, though we didn't call it that. There was a dentist, a dental hygienist and assistant, a medical assistant, a physician, and me, a social worker, a home visitor who was a forerunner of the community health worker, and those very important few offstage players who really make things run. But what catapulted our development of a strong formal model of team-based care was both need and opportunity to do better. Starting in the 90s with the epidemic of homelessness, deinstitutionalization of the mentally ill into our communities, the HIV/AIDS crisis, and moving on through all the challenges we're so familiar with. And we had great coaches, teachers, and innovators at that time. Ed Wagner, Tom Bodenheimer, Mark Wagner, others. In every generation of healthcare, there's huge challenges, and if we meet them, we learn and we lay down new structures, skills, and systems to meet them in the future. Things like, say, a COVID pandemic. So the core team for my organization, similar, I think, to what Tracy described with her PAC teams, the primary care provider, the medical assistant, an RN, shared with 2 primary care providers in my system, a therapist, always. Now that person may be mostly remote by patient preference, but still part of that team. But wrapped around them, what Tracy called the extended team, or I think of as the shared team members, that are based on the needs of your practice. Dietitians, chiropractors for us, podiatrists for us, a clinical pharmacist, psychiatrists and psychiatric APRNs, critical, and increasingly community health workers. If I had to pick out one requirement for a community health center or any other private practice or system to take on really implementing a high-performance model of team-based care, it's to have somebody on the team who has the skills to do the process improvement, work with the teams, coach, develop protocols, develop systems to make it work. The will comes to us intuitively. The practice to be able to do it is very different. We really have to have those trainings. That's part of what we do through our National Cooperative Agreement. And if I had any question about the value of teams, which I don't, but if I did, we only had the COVID pandemic to challenge us and make it clear again. Because it turns out the skills of working in a team are pretty fundamental to responding to crisis, and it's also infinitely replicable in other settings. The culture, the approach to work, the respect for each other, the automatic pivot to designing and creating new workflows is useful whether you're setting up a new site of your practice or whether you're doing something like setting up mass drive-through vaccine clinics, which I know many of us had experience with. So turning back to yesterday's conversation with Judith and Admiral Levine, the NASM report supports all of this. Training people where they live and work, paying for teams to take care of people, not individual providers to deliver services, making changes to GME, something I've been working on for 20 years, to help accomplish the training aspect, reforming the payment system. The HHS plan now has to make that support tangible and make it available throughout the country in order for it to be realized. I think the most powerful statement in the NASM report might be at the beginning and the end. There's a beautiful definition of what primary care is, Barbara Starfield's definition with a few tweaks, I think, and then an asterisk saying, this is not what most people in the United States experience today. That was incredibly brave and powerful. And then the closing, just get it done. I think those of us in this room are really committed to getting it done. Thank you for your time and listening to my thoughts.
I told you they were good. We have some questions coming in already, so what I would encourage everyone to do is if you don't have the Slido app going, please get that moving. We can see on the screens down in front of us what questions you're asking, and so if you see other people's questions and would like to vote them up, to put those towards the higher priority end of the spectrum, let us know. I'm going to ask one question of our panel to get things started, and then we're going to turn to the questions that you all have. So let me ask, any or all of you, one of the themes throughout the National Academy's report, and frankly the presentations we've heard from all of you today, is the importance of a holistic approach to care. Medical, psychological, dental, vision care, but also social determinants of health like education, nutrition, housing, and spiritual needs. Unfortunately, the financial incentives in all of our systems or communities don't necessarily support these kinds of best practices. If you were talking to a key decision maker, such as an official in HHS, the CEO of a medical center or a community center, what things would you tell them? What kinds of, what strategies have you found to be successful to prove the return on investment, the ROI, the value of the kind of a holistic approach in training and in care?
I would say one of the key things is mental health treatment. Having co-located behavioralist is key. Mental health, dental, and vision should also be core parts of the primary care office. And it's when we have all those folks together and can meet those needs in an amount that is commensurate with the number of folks you have in your practice, that's critical. I'd say the one other thing is meeting patients where they are. I think access is an incredibly important thing, and we've gotten very hung up on this 4 square walls of our offices. And there is this potential to go out to where patients are and actually meet them there and provide a great, I mean, look at what the pandemic did for telephone and video visits, but a lot of our patients with their social determinants don't have regular wireless access or Wi-Fi. They don't have maybe a phone where they have the minutes to sit on hold waiting for you. I think that going instead to where they exist in their community, that would be one thing that I would encourage.
Yeah, I would say that I think one size does not fit all ever, right? And not every practice has to have a whole dental team and a complete behavioral health team and community health workers. But some practice has to have it. Generally, that's been considered the community health center. But if there's not a community health center, then you need one with that model of care that's designed, in fact, required to do it. And one of the NASM reports is to look again at where we need either a health center established or we need more settings. I do think every practice needs behavioral health. I think that's fundamental. Yeah. And based on your community, you may or may not need, you do in all of my communities, people who go out into the parks where the homeless are to do the HIV PrEP outreach, all of those things. But not every practice has to do it. So we have to have a logical approach to ensuring these services are provided. And in terms on the return of the investment, you know, it's not to the practice. The return on the investment is to the society, which gets us back, I think, to NASM report number 1, make sure everybody is attached to or has access to a usual source of primary care. That's a benefit to the society. Tracy?
Yeah. And so, you know, with the Department of Veterans Affairs, we have that holistic approach where we have dentistry, we have social services, we have homeless social workers that go out in the community, and we have all of the services. You know, but for us, I would say that the biggest challenge that's coming up very soon is the end of the waiver for the ability for prescribing through telehealth across state lines. Yeah. Mm-hmm. And so for me, you know, we need law to allow us to be able to extend that, or permanent law. So I would say for us, you know, we have the largest integrated healthcare system in the United States. But we do have some fragmented care, and some of it has to do with our abilities to partner and establish through our bureaucracy to establish the ability to partner with schools. And one of the examples, like you talked about dentistry, they're not at every spot. So one of the VAs I came from, there was 5 hours end to end. So if somebody was eligible for a dentist, they had to travel 5 hours. And so we were able to partner with local schools, hygienist schools, and be able to send our veterans there. But for me, I guess the question was, what would be the one thing I could say, and that would be to extend the waiver or implement a permanent law that allows that prescribing among states. And then, you know, perhaps the other thing is one standard practice. Why do we have 50 different state practices for every profession? Yeah. It really makes it challenging. It's a little easier for us, you know, when you're practicing in a federal agency, but sometimes now through telehealth, it gets tricky on our ability to practice.
That's true in training also. someone had mentioned the policy barriers. One of the largest policy barriers in training is who's allowed to supervise whom.
That's true.
And I created this co-located training for all kinds of professionals. And we had to then hire an LISWS and a professional counselor, supervisor, et cetera. It was a huge group of supervising bodies to get all of the training covered, whereas there was so much overlap in the things that we were learning. And in fact, family docs were training the behavioralists were training the family docs. All of that's really important.
Yeah.
And yet those barriers, and those are legal barriers,
right.
licensing barriers, and I think those are big policies that make things hard.
Leanne has beautifully transitioned into the first question that all of you have asked, and a number of people voted up, which are, what are some of the policy barriers that exist and prevent breaking down siloed training? She's highlighted some of them, which are licensing issues. I heard somebody even clap for the barriers that exist from state to state to state around these matters. Anyone else like to add to that?
You know, in my experience, it's the training, the supervision one. Beyond that, I don't really see a lot of policy barriers. I see financial barriers, I see resource barriers, I see will and motivation barriers, but I don't really see a lot of policy barriers. I think it can be done.
There's one other, is the electronic medical record and the non-speaking of different systems. I'm at Ohio University Heritage College, which is a state institution, and we communicate with the Cleveland Clinic. That's our sponsoring institution for the residencies, for the GME side. And oh my gosh, just for the faculty on the one side to send me an email and me to send one back, there's firewalls galore. So just these communication barriers can be enormous. And you have to come up with, you know, tricks behind the walls. You know, we have a Google site that we communicate on because, you know, my God, we can't communicate with each other otherwise. And that can't go through either of our institutions, so we have to talk to each other when we're home. So, you know, little things like that can really gum up the mix.
Yeah, I was just going to echo what you said about the electronic health record. Some of you may know that we're transitioning to a new electronic health record in the VA. And but one thing we hope will be helpful is our goal to have a veteran's lifetime electronic record. And they're in different places trying to break down that barrier where the VA, we can get past that firewall to have that bidirectional electronic health information exchange.
Anyone else who's gone through an electronic health record change, I'm sure, is with you.
It's great.
We have the next question, which is actually about patient engagement. So the question is, what do you do when a patient doesn't resonate with all members of the care team? You can have a relationship or trust ruptures. How do you detect that, and how do you accommodate? Particularly, the question suggests if it was maybe one member of the team who the person or maybe the family isn't getting along with.
Yeah, I'll go with that one real quick. So in the VA, we have patient advocates, and our patients are very verbal and give us feedback every day. Some of it we love to hear, some of it is opportunities. So most of our patients are real, if they come to the primary care team and say maybe they perhaps don't like their physician, they have the ability to request a change of physician or a change of the whole panel. And within the team, they generally identify the person that has the best relationship with that patient, and then most of the communication can go through them. But they do work it out, and we have a large system, so it's a little bit easier that way. So we're able to identify that and talk with our patients and assign them to somebody that they can work with, because trust is critical. So I thank you for that question.
We have two ways of doing that. One is a patient panel that gives us feedback constantly, which I think is really, really important. And they actually help us develop the community projects I mentioned. So they're engaged with us. The other thing is recruitment of a diverse healthcare workforce. So having MAs, nurses, social workers, behavioralists, docs who look like me is totally important. And I think really helps. It isn't just me at Metro Health, right? There's a rainbow of folks that are culturally diverse, language diverse. All of that really helps. It not only helps that patient who finds someone that looks like them, but it also gives me street cred. We borrow that because we're culturally communicating and retraining each other all the time. It's got to be an environment of feedback and training. So
I'll keep it really short and say it takes a lot of time, takes a lot of intensity of effort, and what is going on in our society today in terms of racial and ethnic conflicts, language, bad behavior. We're not immune to it. Maybe you're immune to it in your practices. We spend a lot of time working with people around just the standards of mutual respect in our patient population, but making sure we really address those issues as they happen.
We have just a couple of minutes left. Let's maybe have one person or two at the most answer the last two questions. I really like this one. So primary care for different populations may need different points of focus. It's really a question about specialty care within primary care. So how do we construct teams around issues such as women's health, LGBT plus issues, children, immigrants, et cetera?
I'll go quick. We do have specialty care pact for special populations within the VA. We have homeless pact, we have SCI pact, we have geriatric pact, and so we do provide that women's health teams as well. So just within the VA, we are able to provide that.
we're able to basically nurture that. So we have a very reflective space for our students and try to be very student-centered in the way we want them to, in the future, be patient-centered. They reflect upon the populations of interest. They're looking at social determinants, quality improvement, every single patient that they see. And over time, you see these trends. So we try to amplify that, nurture those interests. So we end up with folks that we have, one of our community projects is in immigrant health in Akron. One is in HIV, LGBTQ care. So by really allowing student passions to drive projects, one can really get all those care members that you need rather than putting them in a curriculum. We're allowing the curriculum to bubble up from student interest. And I think this is a way for the future for us to get all those folks because they're out there, we just knock it out of them in training.
Maybe all the above in 10 seconds, I would say we also have a Center for Key Populations. It's a virtual center, but it's a couple of clinicians who provide expert backup and guidance to primary care providers on any team to become masters of and tackle being HIV specialists, being OUD specialists, being transgender care specialists, so that as many people as possible can provide that care, but they know they've got the Center for Key Population experts behind them for backup, which has been critical.
That's so cool. Yeah.
That's terrific. I think we're going to make that the last question. One of the things I wanted to say as a way to wind up, just on a personal note, I was able to see primary care work really effectively. So my wife and I have 5 adopted kids, and so we were able to see the insides and outs of the foster care system. So a lot of you who have been able to work through state Medicaid programs or be able to work in those kind of settings will know that a lot of times what they do is they'll actually have a team of folks who actually come together on the same day, because these are some kids who've had some of the really most difficult, you've seen that, some of the most difficult issues in their life, and a lot of folks providing foster care are really struggling to make ends meet and to be able to get to appointments because there's so many of them. So what they'll do is they'll have a meeting in one day. That's right, they'll gather everyone together. So just using that as a single example where the funding is terrible, but the intentionality, just like you've heard today, is so strong to do the right thing for some of these kids who have just had a rough go. So I want to say to all of our leaders and panelists today, thank you for your leadership, thank you for the wonderful remarks, and thank you to the audience for your questions. We really appreciate it.
Thank you guys for sharing the stage. Thank you.
All right. Thank you. Well done.